Gabrielle, où es-tu? All right, who's keeping the timer? Okay, so Maddie will buzz you. So the moment I leave, you come in and go.
I'm just gonna start my chronometer on my phone. All right, hello everyone. To begin this afternoon, I want to bring you all on an adventure. So please close your eyes, don't fall asleep, but just picture this. It's a Sunday afternoon, it's sunny, a little bit chilly, but not overbearing, and so you decide to go on a hike in the Rockies. But you have one problem. There are holes in your boots, and so after a while, little rocks are starting to accumulate in your boots, making it painful to walk. You have blisters, your motivation fades with every step you take. And just as you were about to give up, someone passes by and notices the holes in your boots. And so they say they have a repair kit and offer you to help. And so after a while of working together, your hole in your boot is fixed, they are as good as new, and the pain is already fading away. And finally, after all these ups and downs, you make it to the peak. And the viewpoint is definitely worth it. And so you can open up your eyes, and I'm pretty sure you're wondering, how does this relate to opioid treatment dependence, right? So we must keep in mind that not all people start their journey to recovery on the same path. About 30% of people who use opioids also have a depression, and the depression can act in a very similar way to those little rocks in your boots. It doesn't make it impossible to climb a mountain, but it makes it harder. And so we conducted a secondary analysis of the OPTIMA data to evaluate the impact of depression on opioid use and treatment retention. First, as you can see in Figure 1 and Figure 2A, depressive symptoms at treatment entry were not predictive of opioid use or treatment retention. But it gets interesting when we look at the data at week 12 that are illustrated again in Figure 1 and in Figure 2B. When depressive symptoms persisted in time, people had a greater chance of opioid use and double the risk of leaving treatment. And so this is showing how much important it is to evaluate and treating depressive symptoms when we are treating addictions. Previous studies have shown that access and delivery to mental health interventions can change the relationship between mental health problems and addiction treatment effectiveness. And actually, what studies have shown is that when those symptoms are treated, opioid agonist treatments are usually as effective as in people without depression. And so we encourage clinicians to be like a hiking partner. Be aware of holes that people may have in their boot and offer a repair kit to those in need. By doing so, we are likely going to help them to reach their landscape. Thank you.
What was his time?
3 minutes on the dot. Wait, one second.
There's questions, yeah.
The clock is ticking. 2 minutes for questions. Questions?
Over there.
Be shy.
Thank you. I don't know how you got that all out in 3 minutes.
Me neither.
These are the things you didn't have time to talk about. I'm interested in comparing your first figure with your B, and it looks to me like depression severity matters a lot in terms of opioid use, but not in terms of so much for, like, you're not seeing a lot of difference in the curves going down between mild, moderate, and severe. Is that right in your statistics?
Mm-hmm.
What do you think's going on there?
Yeah, that's a really great question. I have two hypotheses for this. So the first one, when we're looking at opioid use, I think that when you have more severe depressive symptoms, and that's actually what the results are showing, the more severe your symptoms are, the more prone you are to use opioids, right? And so I think this might be because there has some kind of automedication effect, right? So people are having a lot of burden related to their depressive symptoms, and so they usually use a little more just to cope with that. But when we look at treatment retention, I think what's really the most important in terms of treatment retention is motivation. And this is a core symptom that whatever severity you have in your symptoms, you will have some problems into your motivation, right? So I think this is why it's less found, like you don't really have that linear effect of treatment of depressive symptoms.
15 seconds.
Merci.
Hello, I hope everyone had a good morning. We got to hear from some health economists, and even though it was my plan to not associate with them, I heard my name said like multiple times anyhow. Less math coming at you. So just to take it a step back, I want you to all think about the last time that you sought healthcare. Why did you go? Was it because you had a pulse rate of 60? Was it because someone told you that treatment was good and you should go? No. More likely it was because you were in pain or discomfort, such that you couldn't enjoy your day and you wanted to get better. We seek healthcare to be able to go back out, enjoy ourselves, and to improve our quality of life. So to focus on that person-centered end goal, there are many pieces, and one is measurement. This morning you heard about a few surveys that measure this with varied length and content. And usually those questions get folded into domains like pain or happiness. These can be combined with weights representing people's preferences to give a number for health status anchored at 0, dead, to 1, full health. And when measured over time, that can give us quality-adjusted life years for use in economic evaluations. So, which survey is best for people with opioid use disorder? Which captures health not just for a snapshot in time, but actually is sensitive to people's change in health? Well, we investigated this, and we found that of these 3 measures, there was no clear winner. So we split the OPTIMA trial into 3 time periods, and for each period, we categorized a patient as either improved or not improved for each of 8 different measures. We'll call them anchors. Now, we paired every anchor up with the 3 quality of life measures to give us over 60 pairs. And this was the basis for 2 analyses. So first, we found that the average quality of life index change score between the 2 improvement groups was statistically different in over 80% of our pairs. And the remaining insignificant ones, well, they happened for each 3 instruments, so not a clear winner. But those are just averages. So then we went along the entire distribution of everyone's quality of life change scores, calculating the sensitivity and specificity of sorting patients into the right improvement group. Those 2 metrics are balanced by the receiver operating characteristics curve, where a higher area under that curve means a better change detection. Well, across the board, we found really just low to moderate ability to detect change. And otherwise, that analysis, the values mirrored those from the averages results, with poorer scores for pairs involving the brief substance craving scale, for instance. So we learned that of all these 3 measures, they all performed similarly and none were great. So which one are you going to use? Well, we need to consider different aspects of validity. We think that these anchors are important because we all use them in our studies. But we should probably talk to people with lived and living experience for this and ask for face and content validity. Maybe we're roping in Lindsay and Kate for that. They might not like that a big portion of respondents are answering just the lowest response option for the 3L. Now, we also found that over half of participants had inconsistent responses.
We have to stop.
Excluding the patient.
Round of applause for Cassandra. She tried. She's here all day today and all day tomorrow. So you can ask her questions about the stuff that she didn't get a chance to finish. But just to be fair, it is 3 minutes. Are there any questions for what she's covered so far? And no, she cannot take the remaining 2 minutes to finish. No? Question, Igor?
So I really like your presentation because it gives a nice message, which is our measures are not great for anything and equally not great, which speaks to improvement. But I'm curious to hear from you, having looked at this data and immersed yourself in this, how might you speculate, or what do you think is the reason why these commonly, widely used measures that everybody says are awesome are actually not that awesome?
Yeah, well, so that's one of the trade-offs. So those three measures, they're generic, which means we can use it in opioid use disorder. We can use it in spinal cord injury, like across conditions to make that comparison. So naturally, we sort of lose out on some of these attributes that are specific to like treatment for opioid use disorder. So some of the anchors were specific: brief substance craving scale, clinical opiate withdrawal scale. The conceptual overlap, it's just different. And so that can help us to kind of explain like why these scores were sort of low.
Thank you.
Thank you so much, Cassandra. Oh, one more question. Okay.
Just out of curiosity, was there any difference?
Wait. No. That's
Okay.
cheating. Nope. You work together. Nope. I won't have it. You people trying to be slick. I pay attention, Ben. And David, you better not raise your hand. No. At least, Boden had some shame. You guys, I don't like that. No.
Yeah, and I
Try.
work with these people, so I empathize.
All right. Thank you
All
so
right,
much,
thanks.
Cassandra. So next up, we have Hamza Bakouni. He's a doctor who completed his medical studies at Damascus University with a where is Damascus University?
Syria.
In Syria. Geography, people. Geography. With a specialization in vascular surgery with a clinical master's degree in 2012. Wow. He completed another research master's degree in health sciences. Then, because that wasn't enough, he completed his doctoral studies in health science research. So he has a PhD from University of Sherbrooke in the beautiful province of Quebec. He is doing his postdoctoral fellowship in biomedical sciences with a specialization in psychiatry and addictology. That's fancy. At the Centre de Recherche du CHUM, University of Montreal. If you didn't get it, he also comes from Dr. Didier Jutrasaswad's team. Take it away, Hamza. Are we ready?
Yeah.
3 minutes, and I'll cut you off.
I forgot everything. Hello, everyone. In early 2022 in Canada, about 20% die daily because of opioid overdose, compared to 10% before the COVID pandemic. And this is because of unregulated opioid like fentanyl, like prescription type opioids, and other opioids. An adequate response to this crisis is require a response with multiple modalities, like improving access to treatment and including improving the effectiveness of treatment, especially the treatment by opioid replacement therapy. Two of these treatments are methadone and buprenorphine. In my postdoctoral study, I tried to answer the following question in people using unregulated opioid. Does higher doses of opioid are better in terms of outcomes than lower doses and of opioid replacement treatment, that is methadone and buprenorphine? And we included 3 outcomes: opioid use and retention treatment, that is keeping more people in treatment, and adverse events. As we can see in the upper half of the slide, one slide anyway, the higher doses of methadone were successfully associated with increased probability of keeping people in treatment. Other outcomes were not associated, and buprenorphine was not associated in few terms. So fortunately, the higher doses of methadone were not associated with higher side effects, but it keeps more people in treatment. So that's good for our population of people using unregulated opioid. And applying my result in real-world clinical setting will contribute to help these people staying in treatment on the long term. However, my research is a small step on the road, and more research is still needed. For example, my other study, in fact, it is on the how fast we may increase the pace of titration of these opioids, for example, methadone. So stay tuned for the next. Thank you.
All right. Merci beaucoup, Hamza.
De rien, avec plaisir.
Des questions?
Thank you very much. I was interested in your no effects of dose on adverse events. Did you clump all adverse events together?
Yeah, that's a great question. In fact, we adopted in the end, we discussed with authors and others, we adopted those adverse events that are possibly or probably or certainly related to treatment, according to physicians. And there was another possibility to include only the serious side effect, but there are no many, so that's why we included it. But keep in mind that we compared the same, most of our population used, for example, here doses between 60 and 120. So in this range, higher doses, lower doses, that is what statistics give us. We don't have many patients that receive 30 or 40 to say that they haven't side effect, or more than 120, there are few, but not enough to gauge that and say really there are more side effects. I think maybe there is, but in future studies maybe we will see.
And just a follow up to that, so in that 60 to 120 range,
most
like,
of them,
is there is that all optimal dose range, or?
No, the range, as you can see, it is 10 to 170. But the 10, it is probably a person that after a few doses switch to something else, can be long-term morphine or something like that. And the 170 is a few people that were more tolerant to higher doses of, maybe they were using fentanyl for long term, so 120 is not enough for them to get the same highs. 180. So that's the answer, yeah.
Any other questions?
Thank you. But,
You know what, maybe I'll ask a question.
I don't know.
So just curious, so in terms of the critical dose threshold being 710 milligrams, and the mean dose being well below the critical threshold, do you think that affected your overall results in terms of retention of the methadone and the non-inferiority study overall?
Yeah, in fact, in the methadone, we separated methadone alone and buprenorphine alone, and the retention in methadone. So if it is switched, it is not retained. So I maintain this because I studied in each section the doses, variation in doses in those randomized to methadone and received methadone, and those randomized to buprenorphine and received buprenorphine separately. Okay, does that answer your question?
It's okay, I'll come bug you afterwards.
Okay, no.
Thank you.
You're welcome. Thank you.
So next we have Victor Mokanu.
Thank you.
He asked me not to introduce him, so I don't want you guys thinking I'm not treating everyone differently. He said, don't introduce me.
Nothing personal. I'd rather do it live. Hi, everyone. The room looks bigger from up here. My name is Victor Mokanu, and I am a researcher and a doctor in training, currently living here in Calgary on the lands of Niitsitapi. And it's my pleasure to present a sub-study of the OPTIMA trial in which I worked with Drs. Sosias and Bozinov. Thank you kindly. And thank you as well to the organizers and for hosting this wonderful event. So, we know that opioid agonist therapy, or OAT, is a safe, effective, and life-saving intervention for people with opioid use disorder. Clinical studies like the OPTIMA trial have been showing that between different medications and models of care, outcomes are pretty comparable. Research is also starting to delve into the complex array of biopsychosocial factors which underpin and affect a lot of these treatment outcomes in OAT. Most of this research comes from the perspective of starting, continuing, and stopping medications. But oddly enough, a fairly unexplored field is medication switches, which is not clinically uncommon and deserves further research. And with the OPTIMA trial, we had a good opportunity to look back on results for people who had randomly started opioid agonist therapy and switched within 24 weeks. So there's a lot of ground to cover, but I'll boil it down to 4 big points. First is that OAT rotation was common. Of the 200 or so people who started within 2 weeks and continued to 6 months, 40, or about 1 in 5, switched medications in that time. 2, this was associated or there was a higher risk of this occurring for people who started randomly in buprenorphine naloxone, even after adjusting for potential confounders and other variables that could influence this association. Third, we found, looking at the specific groups, that this was associated with a number of substance use factors that overall suggest a more complex and more severe opioid use disorder picture, and potentially a higher tolerance that motivated these switches. This makes sense because buprenorphine provides a partial opioid signal. It also partially blocks it. And for that reason, there is a ceiling effect where higher doses don't give you more of a signal, whereas methadone provides a full opioid signal and has no ceiling effect and can be increased further and further to meet somebody's needs who has very high requirements. Fourth, I'll also point out, interestingly, we found that switches were more common in BC than other provinces, suggesting that there are clinician and system level factors that are either promoting or hindering switches between these medications. And so taken together, we know that there are a number of medications and models of care for opioid use disorder, and so far the data seems that they're comparable. So people with opioid use disorder should have choices in the medications. What we add is that opioid agonist therapy rotation is common, and there are certain risks, as with any other medications in medicine, that it might be a risk of not properly meeting somebody's opioid requirements or level of tolerance that requires switch from something that's more convenient to methadone. And people should be supported by clinicians and systems in order to find the medication choice that eventually works best for them. Thank you.
Thank you very much, Victor. Questions? Ooh, David.
Very quick one. Was this hypothesis-driven or exploratory?
So great question. It was a really good opportunity to look at the results of the OPTIMA trial that was already done, and it was more exploratory to see what's out there, and certainly needs further study to see long-term outcomes and really how this factors into overall opioid use disorder care.
In terms of other comorbidities, you guys have examined things such as hypogonadism, issues like that, liver disease, cirrhosis. Like, were those factors that came into play in terms of people switching? Why was that examined in the study?
So it was examined, and I definitely had to trim some details to fit it onto one slide here. It's currently submitted as a manuscript, and there were a whole range of factors. Nearly everything that was captured in OPTIMA we took a look at to see and adjust for in terms of this rotation. And if you're speaking specifically about the risk of switching medications, if you started in the buprenorphine arm, all the things, factoring out one by one so that it doesn't affect the number at the end of the day more than 5%, we found that the only other factor that was associated, which kind of speaks to this story of opioid tolerance and more complex opioid use disorder, was fentanyl. So testing positive for fentanyl at the start of the study was really the only other factor we found that potentially factors into this increased risk of rotation.
Other questions? Thank you so much, Victor. So this was our fourth of 5. It is not easy, really, to present this so quickly. And our last trainee is Laurent Elkriev. He is a third-year resident at the Université de Montréal psychiatry program. He completed his master's in biomedical sciences in the psychiatric sciences option, studying the relationship between genes, substance use, and the development of psychosis. Laurent has a deep professional and personal enthusiasm for men's mental health causes, such as Movember, which explains the mustache. So take it away, Laurent.
Doctor, will pot help me with my opioid cravings? This is something that has been asked to me during my clinical training. And honestly, it's a valid question. Increases in cannabis use have been associated to decreases in opioid prescription across various populations after legalization, for example. And the idea that cannabis can help those with opioid use disorder is supported by individuals with lived experiences. Many individuals report using cannabis to help control their withdrawal symptoms. And cannabis is often referred to as a form of management or self-treatment for opioid use disorder on online forums. But 2 thorough reviews of the studies examining the relationship between cannabis use and opioid use disorder have shown mixed results. That is, while some studies have shown positive outcomes associated to cannabis use, other studies have shown no effect of cannabis or even negative effects of cannabis. So does cannabis really help? And if so, how? My study looked at the influences of recent cannabis use on opioid use, withdrawal, and craving in the context of the OPTIMA study. We hypothesized that more cannabis use in the last week would be associated to decreases in opioid use, decreases in withdrawal, and decreases in craving across the study. We could not confirm our hypothesis, however. While opioid use, craving, and withdrawal were all decreased as the study went on, there was no statistical evidence to point that cannabis played a role in these reductions. So now we got to ask why. Was it the dose of cannabis, grams per day, that is at play here? That is, those individuals who use more cannabis in a given day are the ones who are actually seeing its positive benefits? It's a valid question because a recent study demonstrated just that. Unfortunately, we couldn't measure this effect as we asked individuals if they consumed on a given day and not how much they consumed. Was it the study population? And that's also a valid question because most of the studies demonstrating positive outcomes associated to cannabis use were done in predominantly heroin-using populations, whereas the OPTIMA trial included many individuals that were exposed to fentanyl, which is much more potent, and something this may have played a role. Was it some other factor, such as the dose of the agonist treatment? This is also valid, but these warrant further investigations. At this point, I think the jury's still out on the topic, and future investigation is needed to determine if cannabis can be used as a tool in the management for opioid use disorder. Thank you.
Merci beaucoup, Laurent. Do we have questions?
Thank you very much for that. That was a great presentation. I couldn't help but notice that the why column that you have is all about explaining why your hypothesis should have happened but didn't, which is kind of like assuming the outcome and then trying to figure out why it didn't occur. But I wonder if we assume that your result is real, as in cannabis doesn't work. It's not the dose, it's not the population, doesn't work. Could you talk a little bit about what that would mean or imply for practice?
So actually, I also had to shorten it for the presentation. I'm realizing I was like, oh, for the mic. So I had to shorten it for the presentation, and in our study, we did a statistical test called the Bayes factor to see if we got insignificant results, does the data actually suggest what our results showed? And the Bayes factor was in support of the negative hypothesis, that is, that cannabis doesn't actually work. So that it's a very valid point that should be considered, but still there's such mixed results in the literature that my study can't be taken as a final nail in the coffin for cannabis. It adds to the existing literature that cannabis possibly doesn't have an effect. At least, yeah. Thanks.
Thank you.
Great presentation. Quick question. Would you ever go back to the data and do a retrospective analysis of some of this stuff? Do a questionnaire? I know there's recall bias associated with that, but would that be a possibility to go back to this population with some of these questions?
100%. 100%. Of course, you would get the biases that come with a retrospective study. But I think if we do go back, the most important thing is to look at the dose. Cannabis dose in any study to do with cannabis as a medical tool really does play a role, whether it's with mental health effects of cannabis or in the forms of management. So this needs to be asked, and that was one of the questions that the reviewer was like, "Hey, wasn't this included in your questionnaires?" And unfortunately, we just didn't have the data.
I'm going to need Dr. Stewart, Dr. Yakovenko, and Mo to disclose any conflict of interest. I noticed you asked all of them questions. So I'm just checking it. There's no rigging here, is there? No. To our 5 trainees, please stand up. Everybody, please give them a round of applause. That was hard. That was very, very hard. And I and everyone here appreciate the energy and the discipline and the rigor with which you invested yourself into doing these 3-minute thesis presentations. So thank you. Judges, good luck.